Good afternoon to everybody present. We've been asked to speak in English, which is extremely convenient for me. Even when I speak Hebrew, it sounds like English. But the other thank you I need to say is to Teva for sponsoring the session and for going to the trouble of arranging the session. And I'd like to thank Teva and Dor Charatz and Nizam Borstam and Amir Lerman, who couldn't be here today, prepared this talk. And all I'm doing is giving it because Amir Lerman couldn't be here to do it himself, also for his wife. So I've been asked to say a few words about coronary disease. Now this slide shows why we're all here today and enjoying this wonderful Congress. It's because heart disease and stroke is still the leading cause of death in the Western world, also in Israel. It's ahead of cancer. If you put stroke and heart disease together in men, stroke and heart disease and stroke in women, it's ahead of AIDS. It's ahead of all the money that's going to the other diseases, and it's still becoming the major field of research in the developing world, and is expected by the year 2020 to be a major cause of death of non-communicable diseases globally. We all know from our day-to-day work in the coronary care unit of the young patient with acute myocardial infarction, or the patient from our neighborhood has died suddenly as an initial presentation of coronary artery disease. It's been estimated that more than half the patients are cases of acute MI in men, and about half the patients in women. The event is the first event, MI or death, and you have no warning, and the risk stratification, the primary risk causes being so much enough. If you look at a series of patients, patients have had a first acute MI with no prior coronary disease, no diabetes in young men or younger women. About half of them are considered low risk. And this is what we see every day. Although we see older patients, we every day hear the patient asking, "Doctor, why did this happen to me? I don't smoke, I walk around a lot, I'm trying to be healthy, and yet I'm here with a heart attack." And when you look at the family classification, which I'm being asked to go over in a few minutes, by traditional risk factors, more than half, maybe even 75%, did not even qualify by our present criteria for statin therapy. Here's an example. If you look at a young patient of 45, blood pressure 135 or 85, total cholesterol fairly common. We see these every day: 220, HDL 40, 130 LDL. I mean, about half of that. But this is what it says on the normal range in our Talit lab reports. He may be a non-smoker, no diabetes. So if you look at the Framingham score, you'll see the patient gets a few points for his age, very few. He gets a point or two for his blood pressure. For his blood pressure. His total cholesterol is a little bit high. He's a non-smoker. And basically, the Framingham score doesn't take into account family history and other events. There's a huge unmet need in our ability to classify patients who are at risk. And this is especially relevant in the generation we have generic statins. We have a lot of information. The question is, at what age to which patients should be starting to treat primary prevention? About 10 years ago, this is in JAMA, showing patients again with established coronary disease by traditional risk factors. More than 60% have only one risk factor or zero risk factors. And it's easy to identify people who are overweight, who smoke, who have diabetes and got high cholesterol. But the question is, who should you be treating in the lower risk people? Can we do better in identifying patients with this? Now, I'd just like to change gears and go to a different topic which is related. And that is, what do we know about the pathophysiology of acute coronary events? If you look at people with acute MI, there's been a lot of literature show that instinctively you think a patient who has a highest grade coronary stenosis is at risk. Turns out that acute coronary events happen in a large number of patients, in those with a less than 50% lesion by conventional angiographic standards. So you have the 40% lesion, which has plaque rupture, thrombus formation, acute MI. Just look a little bit about what's going on here in the vessel wall. On the left you see an early plaque, there's a lipid pool, there's some cells, there's a whole story out there of cholesterol, oxidized LDL entering the vessel wall, the mechanisms available, the markers, the BCAM, ICAM, the macrophage response, and it can go sort of two ways. The top picture shows patient with stable plaque. It's a lesion, it's got lipid, it's got some cells, it has a protective fibrous cap which separates the plaque from the lumen and the circulating duct. Opposed to that, the bottom picture, what has become quite widely called thin cap fibrous fibroatheroma, is the situation where we have a thin Teflon lining only, a monolayer of cells with very little tissue underneath that, a large lipid pool, a very cellular macrophages, perhaps inflammatory driven process, and if that's fibrous cap, when that ruptures or erodes, then you have a ruptured plaque, thrombus in the lumen, acute myocardial infarction, sudden death. What's going on in these plaques? Now, if we look again at the picture on the left, there's certain markers for inflammation, and there's a whole new strategy out there in a whole new list of clinical trials and drugs trying to treat the inflammatory response. We know we have markers of inflammation. We have CRP, we have other markers. LPPLA2 is the new one. LPPLA2 content in circulating LPPLA2 and in plaques is fairly low in the stable situation. But on the right, in patients who have thin cap fibroatheroma, large necrotic lipid pool, LPPLA2 is much increased. And you can see that by the dark staining in the slide on the right. So these patients may have minimal stenosis, they have a thin fibrous cap with low collagen content, they have a large necrotic lipid pool, many inflammatory cells, and these are the ones at risk for plaque rupture and acute coronary event. This is what it looks like in pathology. The fibrous cap and the stable plaque on the left, the soft plaque, the lipid pool, the ruptured plaque in the middle with fibrous cap which is very thin, the thrombus in the lumen, and the lumen may not be initially stenotic, but the inflammatory process that triggers perhaps the rupture leading to thrombus formation causes the event. We can identify some of this in the cath. This is from Greg Stone's paper from a prospect study where they did IVUS to the coronary arteries. This is IVUS with color coding, what became known as virtual histology, whatever that means. And the red color on in the vessel wall on the top has been correlated to soft plaque. If you have collagen, it's the green or the yellow. The firmer tissues have a green or yellow color. There is no layer of protective collagen between the red lipid pool and the lumen. And when you follow people with this sort of lesion at the bottom, the red is the patients, the vessels with thin cap fibroatheroma. The blue is people who do not have, who are classified as not thin cap, but who have stable plaque. Most of the events on patients who have thin cap plaques, and as you have more plaques and narrower arteries, the event rate goes up. So this, you can get this sort of information with a new imaging. There have been some attempts to quantitate the LPPLA2 in the plaque. Just look at the spectrum from the left to the early plaque with a lipid pool, thinning of the cap. We see there's a dark red brown staining in the wall. It becomes more prominent in the third picture from the left and in the highest in the picture on the right. And if you quantitate that at the bottom, you can see you go from the stable plough to thin cap fibrous atheroma to vessel rupture. Each stage is associated with higher LPPLA2 levels. So LPPLA2 seems to be a marker that goes up in parallel with the danger of hot inflamed plaques, plaque rupture, acute coronary events, and that's why we're holding the session today. Thank you very much.